Good evening, everyone. We are running late, so without any further ado, I will start the retina session. And we are very fortunate to have a very senior retina guru amongst us, Dr. Giridhar. Actually, sir needs no introduction. He is also he has been president of VRSI, and he is someone we all look up to. But still, I will just like to do the honors by introducing him. So, sir did his MBBS MS from Pondicherry and then VR fellowship from Shankar Netralaya. He has over 2 decades of practice and he's a passionate teacher. And that's why we are really fortunate to have him. He has trained more than 20 young VR surgeons, has over 20 publications and more than 200 lectures in various national and international conferences. He's very passionate also about community work, about creating awareness about diabetic retinopathy and other retinal diseases. And his areas of interest include diabetic retinopathy, AMD, and surgical retinal. So what he will be talking about is a technology absolutely new for all of us in North Bengal, OCT angiography. It is true that we have been having this technology in in few centers, but still I think we have not been really exploiting the power of this technology so far, because we probably all need to learn a bit about it, and who better than Giridhar sir to teach us about it today. So sir, if you are there, please, the stage is all yours.
So, thank you for the introduction, Dr. Somnath. You can hear me?
Yes, sir. Yes, sir. We can hear you. Can
Okay.
just share your slides.
Yeah. I'll just share my slides.
Your
Yeah.
top of your yes, excellent. Thank you so much. Thank you, sir. In the meantime, sir may leave after his talk. So, if we have any questions about OCT angiography, depending on based on his presentation, so we will have that immediately after his talk. So, if you have any questions after the talk, please do let us know. And people who are attending online, you can just message it to us directly through chat, or of course, if you wish to ask sir the question personally, just let me know. Thank you.
So, thank you, sir. Thank you for inviting me. And I'm talking on a subject on which I have not really spoken any time in the past. So, but then of course, we have been doing this procedure in our institution for a very long time, and probably one of the earliest machines of Heidelberg in this country. So we have been using these images, and at least I think I will be able to share some of my our experiences. And my talk will be divided into 2 or 3 parts. One is a short introduction. Second is I'll spend some time on acquisition of image, because I think acquisition of a good Opta image, that's I think the most important thing, because that is where I think most of us in the early stages, we find it very difficult, and also some common applications in retina practice. So I have to thank my colleague who's a medical retina consultant, Dr. Kiran Chandran. He is actually a head of the imaging clinic in our hospital, and he is very good in collecting a lot of good images. So he has helped me in preparing this manuscript. So I have no financial interest, because I'm only focusing on the Heidelberg Spectralis. I do not have any experience with any other machine, and we have been using the Spectralis for nearly 2 decades now, and so we are very familiar with this particular machine. So, however, I have no financial interest. So, OCT angiography, as you are all aware, gives high resolution volumetric flow information of both retinal and choroidal vessels, and we are able to visualize the blood vessels down to the capillary level. I mean, unlike fundus flows in angiography, where this is not possible. And this technique has I would say, improved over the last couple of years, thanks to high resolution spectral domain OCT, and also availability of NPAS segmentation procedures, and also good algorithms with which we are able to get Opta pictures which are quite good and which have a very good resolution, much better than what it was when the Opta came into practice a couple of years ago. So to put the whole process in a very short, in a single slide, as you are aware, what actually Opta does is that multiple high-resolution SD OCT scans are repeatedly done in the same discrete tissue volume, and this detects changes in the reflectivity signal. And this reflectivity signal is based on the movement of erythrocytes within the blood cells, and that is how we are able to visualize the blood cells, the blood vessels in optical coherence tomography. So if the changes are above a selected threshold, flow is considered to be present. So basically it samples a discrete tissue volume, as you are aware, because we select a particular grid, and generates a number of images based on reflectivity, and this numerical value corresponds to a voxel, and each voxel is an estimation of the reflective property. Therefore, as you are all aware, when we do an Opta, after the initial acquisition, there is a small, at least it takes a few seconds or probably a minute for the whole process to go on, for the images to be generated, and finally we get the Opta images. So it is a complex procedure, and basically it's basically based again on the B scans with repeated OCT scans at the same area over a period of time. So how does Opta work? So Opta works, uses motion contrast to detect flow from OCT data. So there is a difference of two OCT B scans, and basically the flow signal overlay on the OCT B scan, which generates finally the image to show the vascularity or the blood vessels in the retina. So the location of the different ENFA zones is very, very important on optical coherence tomography, and basically the three zones are superficial vascular plexus and the deep superficial and deep capillary plexus, and the superficial capillary plexus is between the ILM and the IPL, and the deep is between the INL and the OPL, and between these two layers we have the intermediate, but the intermediate is not something that we normally use much in our interpretation, but it's basically the superficial and the deep. And the most important area is the outer retina between the outer nuclear layer and the Bruch's membrane. This is the avascular area. So you can see here, this is the superficial plexus, this is the deep plexus, this is the outer retina, the photoreceptor area between the outer nuclear layer and the Bruch's membrane, and this is the choriocapillaries. So it's very important to know these ENFA segmentations, because especially when you do the manual segmentation, the outer retina, we should understand these things so that you are able to get a proper segmentation. So this is the normal picture that we see on the extreme left is the fundus fluorescein angiography of a central macula of a healthy subject, and this is the Opta 3 into 3 millimeter of the. This is how the superficial plexus looks like, and you can see the web-like shape towards the fovea, and this is the deep capillary plexus showing a very close-knit pattern of vessels around the foveal avascular zone. So this is how we differentiate the superficial and the deep plexus. So it's very important to know what's the normal size of the foveal avascular zone. This is basically only important in diabetic macular edema. So this is just a picture to show you the normal foveal avascular zone, both in the superficial and the deep plexus, and this is usually about 3 into 3 millimeter in both the superficial and deep, and the the volume is about 0.299 square millimeter. So this is how we see in a display screen. Once we have done the optical coherence tomography, you have the ENFAS image here, and the ENFAS image shows the area of interest, and the ENFAS image also shows the grid that we have chosen, or the area that we have chosen to do the optical coherence tomography. On your right is the the Opta image, and this is the superficial and the deep vascular complex, and this is the avascular complex. So this is what we normally see, and this is basically the display. So once I just showed this particular thing, because it basically to just show you how the ENFA segmentation is done as far as the superficial, deep, and the avascular complex is concerned. So the scan patterns, now I come to the, acquisition of good images. So the scan patterns are very, very important. The scan patterns could be either a large scan pattern. This is basically to see a relatively large overview of the retinal and choroidal circulation. This is not used very often in our practice because our use of Opta is basically for macular diseases, and this is basically to study the evaluation of capillary dropout in retinal conditions such as diabetic retinopathy or retinal vein occlusion. The more useful is the 10 into 10, where we get a more detailed evaluation of vascular abnormalities at the capillary level. As you can see here, the superficial, intermediate, and the deep capillary, deep plexus, and you can see the differences between the three images. So there are three patterns of abnormalities that we see in Opta. One is the abnormal presence of flow, that is the neovascularization, abnormal vessel geometry like dilated vessels or aneurysms or telangiectasia like you see in macular telangiectasia, or absence of flow, that is basically non-perfusion or CNP area. So these are the three important abnormalities that we look for in OCTA. Now I come to a very important three or four very important slides, because this is very, very important. So this is basically, once you have acquired the images, this is the display screen. So you can see in your top left here, this is the display screen here, and this is where I showed you earlier, where we have the NFAS image. We have the SD-OCT scan of the high resolution SD-OCT scan, and also this to a certain extent may also show you the flow pattern. And then we have the superficial, deep, and the avascular complex. In this, the avascular complex, where in this particular area you can see here is showing you a neovascular network. So this is the display of this thing. So the moment the Opta is taken, this is what we normally see. The next one is what we call is the whole retina Opta. So after display, if you press the OCT angiography button, then you can see the other portions. That is, one is what is called is the whole retina Opta. So this is the whole retina Opta. Now basically the whole retina slab showing the lesions of interest on NFAS Opta. So you see this is the NFAS, and this is the area of interest. Now in this particular patient, this is actually a case of macular telangiectasia. You can see the right angle vessels beautifully, and you can see this particular right angle vessel bending like this and dipping into the retina, and at that point of area we can see a suspicious neovascular area. So the SD-OCT also, if you see in this particular area where there is a dip and there is basically a suspicious network, there is an increase in the thickness of the SD-OCT, and there are also some outer retinal hyperreflectivity and suspicious flow signals here. So the next button is the whole retina is very useful, especially in certain specific conditions like macular telangiectasia, where you are able to identify some of these right angle vessels and also some of these vascular abnormalities which otherwise are not available, seen well in any other imaging technique. So the next, after the whole retina, then we move on to each one of these areas, that is SVC, DVC, avascular complex, and below the choriocapillaries. So this is the next, particularly in the avascular complex. So in the avascular complex, you can see here this particular the neovascular network. So once you are reaching the choriocapillary area, you can do what is known as a manual segmentation. So manual segmentation is very important, especially when you are looking for small neovascular networks in the outer retina, which may not be otherwise, you may miss, or it may be covered up by an artifact or a projection artifact. So here we are doing what is known as a manual segmentation, the ORCC manual segmentation. You can see the two cursors here, and these are the two cursors just within that area of hyperreflectivity. That's very, very important, where you keep the cursors, and once you keep the cursor in these two areas, you can see this neovascular network. So this manual segmentation is a very important technique, and that is where probably the need for the surgeon or the consultant has to inform the particular technician at the area of interest where they can do a manual segmentation and discern the neovascular network. So you can see here an enlarged image showing you the NFAS ORCC Octa, showing you this basically the correct segmentation, where you can see the two cursors are there within this area of the outer retinal hyperreflectivity, and also you can see the flow signals within that particular area, the flow overlay. So basically this shows a well-defined network subretinally at the level of ORHR in a stage 5 mactal. The OCT with flow signal overlay is depicted below, showing dense clustering of flow signals at the level of the ORHR, and the boundaries of the segmentation line, the red dotted lines, are exactly enclosed within the ORHR lesion, and that is very important. So you can see here the boundaries are within the ORHR lesion, and that's why you're able to get a correct segmentation. So this particular picture is just to show you how one segmentation is wrong and the other segmentation is correct. Now if you see here, the red arrow will tell you where the outer red line is. This is above the area of the ORHR. So the anterior demarcation line is placed higher than the area of interest, that is, and hence projection artifact of vessels from the DCP are being displayed around the neovascular complex. So this is where, whereas here if you see, it is kept within the ORHR, and that is why the DCP projection artifact is completely absent. So whenever you have a projection artifact, it is very important for us to do a manual segmentation, get rid of a projection artifact, and identify the correct neovascular network. So interpretation. So now I come to the next stage of acquisition and interpretation. So these are the first 8-10 slides, which I think are very important, because all of us know the applications of Octa. But the main issue is basically acquisition of images. So in an interpreting an OCTA, step 1, evaluate the Octa and B scans. So this is very, very important. So focus on the outer retina slabs, that is outer retina A, B, C, C, C. So here you can see multiple cuts of the OCT, and you can see the subretinal hyperreflective material. And we know that the area of the subretinal hyperreflective material could be the area where the neovascular complex would be there. So it's very important to do the segmentation there within the AVC in the outer retina, and basically you can see this neovascular network in the AVC, and you can see the choriocapillary area where you can see that very faintly, but this is the area where the neovascular network is, and this is particularly corresponding to this area of subretinal hyperreflective material, and it's ellipsoid type of hyperreflectivity that is very characteristic in a case of type 2 neovascular membrane. So this is again just to show you how the flow overlay of OCT is very important for us to detect the neovascular network. So here you can see the outer retina AVC showing you the neovascular network, and this is the choriocapillary. Here you can see that cursor, the red lines, which in the choriocapillaries. So step 2 is look at the B scan with flow overlay. This is very important. So on your left is basically a B scan where there is no flow overlay, there is no M and V. On your right is basically a B scan to show you the presence of neovascularization and also the flow overlay. This is basically the presence of this double layered sign and irregularity of the PED, and here you can see this neovascular network. Look for false negative. This is very important. False negatives could be either due to shadowing because of fluid. Here you got a fluid under a pigment epithelial detachment, which can cause a false negative image, or presence of a hemorrhage. So these are some situations in our practice where Octa may not be a very effective technique for us to diagnose a neovascular network. So here there is a presence of a hemorrhage, which again is acting as a false negative. This is again a very, very important slide. In eyes with geographical atrophy, where there is complete loss of outer retina, and there is thinning here, in such cases you can see the decreased autofluorescence also. You get a false positive because the choriocapillaries are projected, you get the projection artifact from the choriocapillaries when you scan the outer retina. So this again is an important false positive, and this again should be kept in mind. Then projection artifacts. Projection artifacts is again another important cause for false positive. So projection artifacts arise when blood flow of superficial layers of the retina is projected onto the deeper structures below. If there is a motion in a superficial retinal vexel, for example, there can also be motion in a shadow behind it. So basically, you can see the projection artifact here: SVC, DCP, and AVC, and you can see the projection artifact of the deep capillary plexus within the AVC. And there is a built-in software. There is a built-in software which removes projection artifacts, and you can see the projection artifact which is present here is removed, and you can see the ORCC layer better in the visualization of the macular neovascularization. So this again is a very, very important cause for a misdiagnosis or a misinterpretation of an image. Then segmentation errors is again another important, as I had told you earlier also. Earlier also I had shown you another case where segmentation error can result in a wrong interpretation. So this is the same slide which is again being shown here. This is a wrong segmentation and this is a correct segmentation, because you can see the cursor lines are within this area of hyperreflectivity, and that's where you're able to get the neovascular network very well. Applications of Ophtha in practice. Neovascular AMD, three types: type 1, type 2, and type 3. We are all aware of that. Type 1 is the most common. The second type, which is the most common, is the retinal angiomatous proliferant. Okay, and the third and the least common type is the type 2 MNV. This is very important for us to understand. So in a patient with a neovascular AMD, we are looking into multiple things. One is the shape. The second is the branching pattern. Third is the anastomosis. Fourth is the morphology of vessel termination. And fifth is the perilesional halo, which is an indication of activity in Ophtha as far as a neovascular membrane is concerned. So we are all aware that there are multiple types of networks that we see. One is what we call as a C-fan network, as you can see here, which the 90% of the membrane radiate from one side of the lesion. You can see it radiates from one side of the lesion, and numerous tiny branching capillaries are seen, which are coming from, at the termination of the C-fan neovascular. This is a very, very important feature of a C-fan neovascularization. The other one, as you are aware, is the medusa head, where vessels branch in all the directions from the center of the lesion. So these are the two important types that we see as far as the neovascular network is concerned. The third is, of course, the ill-defined type. This sometimes we see in small types of inflammatory neovascular membrane. I will show you one or two cases where we see ill-defined neovascular membrane. And the last is what we call as the long filamentous. These are basically a dead tree appearance, which shows that there is hardly any activity as well. So once you find this sort of a picture where we see only these main vessels and no smaller vessels here, that means basically there is not much activity, and this may remain like this for months or years together. So the Ophtha biomarkers in AMD CNVM, as I told you, is the perilesional halo, increased complexity of branching and capillary sprouts, because Ophtha, as far as in neovascular AMD, has got two applications. One is diagnosis and second is, I think, follow-up. In follow-up also, although OCT is very good, it tells you whether there is activity, but the picture that we see in Ophtha probably can tell us how early there can be a recurrence as far as a neovascular membrane is concerned. Lesions with large trunk vessels with minimal branching indicate very minimal inactive networks, and they do not require therapy, and probably they can have a longer duration, longer gaps, or the follow-ups can be stretched out more when compared to eyes, where we still find quite a lot of branching and capillary sprouts, although the OCT is not showing any activity. So I will be showing you some cases now. In a type 1 macular neovascularization, you can get both the medusa head and also you can get the C-fan type of a neovascularization. This actually is a case where there is no activity, a non-exudative CNVM where within the double layered sign or the irregular PED, you can see a neovascular tuft which is growing. So basically, this is a very important information, because this tells us that this patient will need a very, very careful and short follow-up. One of the most important applications of OCTA in neovascular AMD is, as you may be aware or may be aware, is the type 1 macular neovascularization, because type 1 macular neovascularization can sometimes mimic a central serous chorioretinopathy. This is a patient where we have got a irregular retinal pigment epithelium, minimal serous macular detachment, suspicious minimal subretinal hyperreflective material. So, of course, experienced retina specialists, by looking at this OCT, probably will have a strong suspicion of a neovascularization. Fundus fluorescein angiography or even ICG angiography may be inconclusive, but optical coherence tomography angiography will be diagnostic. As you can see, the CFAN type of a neovascularization, which is very evident in this case, a neovascular complex at the sub-RP level with flow signals, which is seen with the yellow arrow. So whenever we look at the neovascular network, we should also look at the flow signals, because the presence of flow signals tells us about the activity of the neovascular membrane. So in a type 1, it's a very, very useful method of diagnosis. In a type 2, OCT, of course, is very diagnostic. When we see this sort of a hyperreflectivity with EIRF and SMD, we know that this is a case of a coronal neovascular membrane, but it is very important for us to document the neovascular membrane, and OCTA is a useful non-invasive technique. And unlike the previous membrane, where we do not see much of an anastomosis and crowding, here you can see the amount of anastomosis and crowding, which shows the extent of activity of the neovascular tissue in this particular case. So type 2, that's why, is more active disease, where the disease can progress very fast. And you can also see the extensive flow signals within the neovascular tissue. So in a type 2 neovascular membrane, actually, we don't need to really do fluorescein angiography or any other invasive modality, because if we have an OCTA and an OCT, you will be able to diagnose the neovascular complex in most of these eyes when you do a proper segmentation and examination. So basically, you can see in this particular case. So as far as follow-up is concerned, actually you can see the complete regression. So why in follow-up this is important? OCT also showing you significant improvement. So why can't we just follow up these patients just with OCT? Basically, I feel that OCTA is useful to tell us how much of the neovascular membrane has regressed. Now, in this particular case, when you see this sort of a regression, you can possibly tell yourself that probably within the next 3 to 4 months, there is hardly any chance of this neovascular tissue to recur, because basically the quantum of regression of the neovascular tissue is very significant. So to that extent, I feel OCTA is quite because in the management of neovascular AMD, especially if you want patient complaints, there are two areas. One is how we can reduce the number of injections and how we can reduce the number of visits to the clinic. So this is another type where we have seeing two types of membrane. If you see the OCT here, you see some hyperreflectivity here, and in this side you see some serous macular detachment, and also you see some irregularity of the retinal pigment epithelium. Now, if you look at the OCTA, you can see two types of neovascular network. One neovascular network here, something like a medusa head. One is the medusa head, and the one is the CFAN type of neovascularization. So you're finding both types of neovascularization in a single patient. So because basically, if you look at the OCT also, it is suspicious of two types of neovascular, because the presence of the SHREM and also the presence of the irregularity, the PED, tells you that there could be a neovascular network here, there could be a neovascular network here. And this is a patient. So in an OCTA, you are able to, is able to pick up such subtle changes also very effectively. The next type of the neovascular AMD is RAP. In RAP, actually, the clinical features, of course, in an established RAP is very characteristic. Like this is a patient with stage 3 RAP, where you are already seeing a large PED. Once you see a large PED, you know that already the patient from an intraretinal, we are already having a subretinal neovascularization. So in this sort of a picture, probably, clinically itself and also with OCT, we have got a strong suspicion of a retinal angiomatous proliferation. Multimodal imaging, of course, is very, very useful. You can see here the anastomosis in ICG angiography, and this anastomosis is right at the roof of this PED where you get a small notch. And you can also see in fluorescein angiography the leakage in that particular area. If you see the octa actually slab is taken on the roof here where you can see the flow signals, and there you can see this network which is growing from intraretinal to subretinal. You can see this network. Octa is also useful in these sort of cases for follow-up where you can see the regression of the neovascular tissue over a period of time with treatment. So you can see here the neovascular tissue has significantly reduced after treatment, corresponding to the changes that we see in OCT. So in as far as RAP is concerned, number one, when we have a large pigment epithelial detachment, it may be difficult for us using Octa to diagnose the neovascular network. The other imaging techniques like ICG angiography may be more useful and very effective, as you can see in this particular case. But nonetheless, with careful segmentation, it may be possible for us to identify the neovascular network. The last type is the mature vessels. So you can see here the mature vessels which more or less remain the same over a period of time. There is no change at all. So these are basically eyes where the disease has practically become nearly inactive. To summarize the utility of Octa neovascular AMD, I would say that number one, it's very, very useful in type 1 macular neovascularization. It is also very useful in type 2 macular neovascularization, especially unless and until there is significant hemorrhage in the macula, which may act as an impediment to a good Octa image. It is useful for follow-up of patients because it tells us the degree of regression of activity, and also in patients where there is only the mature vessels, we can probably tell ourselves that the possibility of recurrences may not happen in the immediate future. The limitations are quite a few. It may not be very useful in eyes with large pigment epithelial detachment, eyes with hemorrhage, etc., where it acts as a limitation for getting a good Octa image. So in polypoidal choroidal vasculopathy, again, it may not be able to identify the polyps because polyps have a very slow flow, and that may not be picked up by Octa signals. So we may be able to see the network, but we may not be able to see the polypoidal dilatations unlike many of the patients. So in polyps, probably from a diagnostic point of view, OCT probably is more diagnostic if you do not have an ICG angiography. Otherwise, you will have to do an OCT and ICG angiography to document a PCV in many patients. This is another case of polypoidal disease where you can see that this is the polyp, and you can see in the Octa, in that particular area, you see a small neovascular network, but you can't really identify the polyps like what we are seeing in ICG angiography. In macular telangiectasia, actually, Octa is a very, very useful technique. Nowadays, we are seeing more and more patients with macular telangiectasia, and basically this is definitely, and we have been doing a lot of work in mactel for the last couple of years. This is basically what I just like to share that we also documented the presence of telangiectatic vessels in Octa even before there are signs in the OCT. These are patients where the other eye has got established mactel. The fellow eye is absolutely normal, but even in the fellow eye, in the absence of any OCT changes, the Octa is able to identify the telangiectatic vessels, telling us that basically the patient has got very early macular telangiectasia. So this has already been reported by us a couple of years ago. Apart from this, in macular telangiectasia, Octa is very useful for us to identify areas of neovascularization. So this is a particular case. You can see the picture. You can see some degree of parafoveal pigmentation also, and you can see the macular mactal zone, which is a large area that's involved in multicolor photography. And if you see here, when you see outer retinal hyperreflectivity in macular telangiectasia, it could be either because of RPE fallout, or it can be because of subretinal hyperreflective material from a neovascular membrane. So when you see the increase in the thickness of the retina along with hyperreflective material, there is a strong suspicion that the patient is having underlying neovascular membrane. So if you see in this particular case, you can see the neovascular tissue corresponding to the subretinal hyperreflective material in the AVC. And this is the superficial plexus, the deep plexus showing you the telangiectatic vessels. And at presentation, you can see, and this patient, of course, received multiple doses of intravitreal anti-VEGF injections. With intravitreal anti-VEGF injection, you can see there's a regression of the smaller vessels and the larger vessels remain. So in myopic CNVM, Octa is a very, very useful technique. Sometimes you are able to detect myopic CNVM even before fundus fluorescein angiography using optical coherence tomography. So this is actually a doctor with high myopia. The right eye is amblyopic with CF 2 meter, left eye is 6/9. And you can see the macular picture. There is a small, suspicious area of what you call a shrem here. And when you see the OCT careful, one is of course OCT also has to be done very carefully. You can see the small area of hyperreflectivity here, and this is probably a very important indication that this patient came with a sudden onset of slight scotoma and a metamorphopsia with slight decrease in vision, and you can see the small area of hyperreflectivity at presentation. Now, the patient was just followed up for 1 or 2 months, and you can see this particular area was slightly increasing, and there's a strong suspicion of subretinal hyperreflective material here. And at that point of time, the Octa did show a neovascular network here. So, Octa is very sensitive to pick up early myopic macular CNVM, and you can see the small neovascular network, and this patient was treated with intravitreal anti-VEGF injection. So subtle changes in OCT and careful Octa can detect very early myopic macular neovascularization using optical coherence tomography, angiography. So MNV in myopia may be present very subtle clinically, and in this particular patient, actually early in the I don't have the FA images because for want of time I didn't want to load too many images, but early FA did not show much of a leakage at all, but then the Octa was able to detect the neovascular network. Of course, in established myopic MNV, it's not very difficult. There's an established MNV, myopic MNV, where you can see this large neovascular network. And and post-treatment, you can see the significant regression. So from the patient education point of view also, Octa is a very useful technique for us to explain to them this abnormality, and also post-treatment when we show these sort of changes, the patient also is able to appreciate and understand the disease. In central serous chorioretinopathy, we may have a type 1 macular neovascularization. As you can see here, fluorescein angiogram shows a suspicious leakage here, but Octa is able to see, you are able to see the CFAN type of a neovascularization, which is very, very evident here. So one of the other important usage of Octa, I feel, is in patients who have some subtle changes in OCT, where you can do an Octa. So this is a patient asymptomatic. You can see there is a 58-year-old man. You can see this slide. He has got minimal metamorphopsia. You can see this irregularity in the retinal pigment epithelium, what we nowadays describe as a flat irregular pigment epithelial detachment. But then there is no evidence of any fluid or any intraretinal fluid or any increase in thickness. But the Octa is able to show you a silent neovascular network. So basically, these are patients probably which have to be followed up very carefully, because these patients can definitely present later with activity. So you can see this particular patient in 2017 and 18, he was asymptomatic, but finally in 2018 he came back with minimal fluid, showing that slowly the network is also growing, and also the network is slowly getting active. So in inflammatory macular neovascularization, there are some applications. Now this is a patient with my own patient with PIC, punctate in a choroidopathy. You can see this active. So sometimes in an active, when there is some active, in an active disease, we may get confused whether this is an activity of the choroiditis or whether there is an associated CNVM. So this particular young lady, you can see this yellowish deep lesion here, and surrounding that you can see quite a lot of fluid. And when you do the OCT through those areas, you can see a lot of intraretinal fluid, and you can also see some subretinal hyperreflective material. And Octa through that particular area showed a neovascular network, and this patient was not only treated for the choroiditis but also treated for the neovascularization, because this patient actually, the other eye was already lost because of PIC with a large macular scar due to an untreated or improperly treated choroidal neovascular membrane. But this patient was identified at a very early stage, and it could be managed very effectively. So again, in these sort of patients, one is the OCT helps us to identify the area of interest, and Octa therefore through that particular area of interest may be able to, with proper segmentation, may be able to identify the neovascular network. So this patient actually has been under my treatment for many years now. You can see now for quite some time there is no activity at all. And even during follow-up, when they come for regular follow-up, 3 months, 6 months, etc., this patient is on mycophenolate methylphenidate. When they come for long-term follow-up, apart from OCT, once in a while we can repeat the Octa to see whether there is any slow recurrence of these neovascular membranes, which will be silent initially, and that tells us that we need to shorten the duration of follow-up in such patients. In other forms of inflammatory disease also, you can use Octa to diagnose the neovascular network, especially in situations like this where you have a heel scar because of choroiditis, and when patients come to you with a sudden decrease in vision, sometimes some of them it's very diagnostic when you see a subretinal hemorrhage, etc., but sometimes we may not be able to see very diagnostic features, and we are confused whether the patient is having symptoms, whether it's due to a recurrence of inflammation or whether it's a neovascularization. In such situations also, Octa can be used for diagnosis of an inflammatory neovascular membrane. In diabetes, I do not use much of Octa in diabetes, to be very frank with you all. I'm not using much of Octa in diabetes. Somehow I do not find it very useful. My main diagnostic utility is OCT and fundus fluorescein angiography. But then in Octa is of course useful in identifying a large, a foveal avascular zone. As you can see in this particular case, the fundus fluorescein angiography also showing a suspicious increase FSZ, but Octa is probably more sensitive. However, when there is edema, etc., it's very difficult for us to identify critical features in the diabetic eyes. And basically, after treatment, you can see here the picture gets much better. So once the fluid has decreased, you can see that the details are more evident as far as the Octa is concerned. So I am not spending much time in my presentation on the utility of Octa in diabetes. At least in our center, we are not using it to a large extent. So, of course, having said all this, there are some limitations of Octa, but most of the limitations I think are basically because of the acquisition techniques. And once, in fact, even when we got this equipment many years ago in our center, I don't think we were using it as much as we are using it now, because probably there was a learning process as far as how to interpret and how to I mean acquire the images and how to interpret the images. So with these few words, I would like to stop my presentation. I hope I was able to give a reasonably good information. Thank you.
Thank you so much, sir, for that wonderful for that wonderful talk. It was really a master class because you covered everything, right from the technology behind Octa to the limitations of Octa and to the way that it has really substituted OCT and and also angiography in certain clinical indications. Especially, I love that point where you highlighted clearly that if we have an Octa and we have given an injection in a neovascular AMD, and we can see the membrane is completely gone, then we can actually switch to a PRN mode and wait a longer. So it is such an important and beautiful point, because like in Siliguri and these small towns, patients do find it very difficult to keep taking injections. That was really an amazing point.
That problem is there everywhere. In our country, I think everywhere that problem is there. Patient compliance and travel is a big problem.
So there are some very few senior ophthalmologists here, sir, Dr. D.B. Sarkar, sir, Krishnan Duda, and others. So any question or comment, sir, for you? Because Dr. D.B. Sarkar, sir, probably had the first Octa of our region. So if I'm not wrong, in Kuch Bihar. So if you can please give a mic to sir. So any questions, sir, for Dr. Giridhar?
Actually, thank you, Dr. Giridhar. You have explained so many things clearly. So I have no questions as so Octa is really useful. So I am using it. I am using Topcon OCT.
Oh, great. I think once we get used to one machine, I think we are happy. I mean, it's a question of getting used to a particular machine.
Yes.
Right. So there is a question online through Dr. Twinkie, who is a Vitreous Retina Surgeon based in Sikkim, and she just recently completed her fellowship from Shankar Netralaya, Guwahati. Her question is, first of all, she again congratulates you for an excellent presentation. And the question is, how do we make sure technically that the same area of macula is evaluated during follow-up? So the registration process
in the Heidelberg, and fortunately we have the eye tracking, madam. So in the Heidelberg, it's very easy to track the same area for follow-up. As I told you, unfortunately, I have not used the other machines. So in Heidelberg, the eye tracking, I think, is one of the, I think even for OCT, we are able to get the same section. So, I mean, that is probably one benefit in the Heidelberg system, where it's the machine itself tracks the area that was scanned earlier.
So the young ophthalmologists, Dr. Utpal, you are a specialist physically present. If you have any comment or question for sir, please. The
presentation. Thank you, sir, for the great presentation. I mean, it was really, as he said, I mean, Dr. Chakraborty, it was a master class. Thank you. No question.
Actually, I mean, thanks to Dr. Somnath, I also spent quite a lot of time with the machine, and that helped me to making a good presentation, especially this segmentation errors and acquisition of image, everything. So last 2-3 days I was sitting with the machine, and I was also taking some scans. So like that, for me also it was quite a good exercise. So my knowledge of Octa has improved a lot thanks to your invitation.
Thank you so much, sir. Thank you. So any further comments or questions from the or else I think we will probably sir, if you wish any questions. So I think there are no more questions or comments.
Okay, thank you. Because I just recovered from a viral. That's why I was coughing, in the middle. I still my nose and throat up quite bad. That's why I would like to just exit after my presentation with, and thank you very much, Dr. Somnath. And
Thank you so much, sir. In spite of your
I'm very happy to see so many people sitting in your hall even at this time of the day. I mean, that really is a great.
and also because we are transmitting webcasting it, there are more than 30 people online also, sir.
Yeah, I know that. Yeah.
It was really, sir, worth all the patient. I mean, waiting because your class was really amazing, sir. Thank you so much. In spite of your ill health,
We'll meet up very soon. Okay, sir.
thank you so much, sir. Thank you.